a lot of these kids are missed. Oh, this kid isn't autistic. Maybe they get what's called an ADOS, the Autism Diagnostic Observation Schedule. They don't meet on it, and a provider is saying, nope, they're not autistic, and that leaves parents really confused.
When someone avoids even the simplest requests, it can look like defiance. But sometimes it's something deeper. What is a PDA profile of autism, and how can families find support when it's not even officially recognized? Psychologist Dr. Taylor Day is here to talk about neurodiversity affirming assessment and how her whole family approach helps kids with PDA and their parents feel understood and supported. That's straight ahead on episode 270. I'm Emily Kircher-Morris, and this is the Neurodiversity Podcast.
What is neurodiversity? You see the world differently.
Autism spectrum.
Gifted.
Complexities that are inherently inside.
ADHD.
Dysgraphia.
Tourette's.
All brains are different.
You are exactly what this world needs.
This is the
Neurodiversity
Podcast.
I wish I'd had a manual for those moments when you know a student is capable of more than what's showing up on paper, and nothing you try seems to bridge the gap. I remember a kid who was brilliant in discussion but completely shut down when they were asked to write. People said they weren't trying, but I knew we were missing something more. Those are the moments that inspired us to create the Neurodiversity University. We've got practical affirming courses on topics like dyslexia, twice exceptionality, and neurodiversity affirming therapy. Tools that can help those almost moments finally make sense. You can find it all over at neurodiversity.university or just click the link in the show notes. Dr. Taylor Day will be here in a minute.
previously on the Neurodiversity Podcast.
Maybe your kid's not going to sign up for the baseball team or go to birthday parties because those are wildly overwhelming and out of their comfort zone. Maybe the kinesthetic stuff is really tough. Dropping a neurodivergent kid off at a birthday party who needs something really concrete, that is the antithesis of that. But being in a virtual Dungeons & Dragons program where I have a role, I know who I am, I can be an avatar, someone that has traits that I aspire to be, that is really attractive. And that might build more confidence. It might help me find people. And maybe anecdotally we're sharing stories and I find something that the real human me, not my avatar, has a connection with that person, and then we kind of hit it off that way. A big part of us has to just let go, ask ourselves why. We have to ask, what are we hoping for? And let go of the how.
That's episode 250. Find it wherever you get your podcasts.
Today, I'm chatting with Dr. Taylor Day. Dr. Tay is a licensed psychologist who works with autistic kids and their families, and she's all about providing support that's actually helpful, not just for the child, but for the whole family. She's the founder of Dr. Tay Concierge Clinical Care and developed the whole family approach, which focuses on making autism care more connected, personalized, and supportive from the start. She's also the host of the podcast Evolve with Dr. Tay, the podcast for parents of autistic kids. Her interest in this work started early. Her younger brother was diagnosed with autism as a toddler, and that experience has really helped shape the way she thinks about family-centered care. So, Taylor, I'm so glad that you're here. Welcome to the podcast.
Thank you so much for having me, Emily, and I'm really excited to be able to dive in, and I refer families to your podcast all the time as a resource. So excited to be here.
I'm also really looking forward to digging into the things we need to consider when we are both identifying and supporting kids who fall into this category that isn't really super well known or understood outside of the people who are really involved in the neurodiversity community. And that's this profile of autism that's called PDA, which stands for pathological demand avoidance, although some people prefer the acronyms pervasive or persistent demand for autonomy. So I think it'll be really helpful to anyone who is newer to this concept to start off our conversation just with a basic description of what PDA is.
Yeah, I think it's really important to say this from the get-go, is PDA is not a diagnosis. It's more a conceptualization. And it really needs a lot more research. But one of the things I think is so important is that we're validating lived experience. And so I'm hearing from family after family, they read about it and they are thinking, wait, this describes my child. So these are things like, their child is having really intense meltdowns, that they are, a lot of times they appear socially interested, but they either mask their traits quite a bit, or they go into these like creative worlds where they're role playing a lot. But at the core, when we think of PDA, what we're often thinking about is how the nervous system is going into this fight or flight mode, and it's overreactive to what seem like everyday demands. So it's kind of that like hypervigilance. I often like to think about it as a really anxious kiddo who's on edge all the time, and they're getting easily overstimulated and overwhelmed, which is leading to a lot of avoiding, everyday tasks, as well as more meltdowns or intense behavior like aggression.
Mm-hmm. I feel like it's really important to recognize where the research is, what the diagnostic process is. So often when we go and talk to educators or other clinicians or medical professionals, sometimes if you're really involved in this community, you use these terms that aren't necessarily understood as well in other environments. And I actually feel like that is often a barrier to care, because people are dismissed because it sounds like they're just repeating something that isn't necessarily in the research, which recognizing like there's a process there for that. We also have to live in this world and be able to access care in the best way possible.
Absolutely. And it's one of these things where I do really encourage like educators, the medical community, to get more up to date on these neurodiversity affirming practices, even if they're not quote unquote evidence-based yet. And that's because research is insanely slow. I used to work in academia. I worked on research projects, from the start of conceptualization of like, oh, I want to study this, to the time that it's actually peer-reviewed and published is incredibly lengthy. And I think this is a whole piece of the neurodiversity movement, is listening to autistic voices and listening to people who are navigating this, and we can learn so much. So I always like to really think of finding a balance there of how do we integrate both pieces. And it's something that I love being able to collaborate, with educators on, or other medical professionals, to help them better understand what is going on. Because far too often, I work primarily with kids, but I hear parents getting dismissed. I hear them being told it's a parenting issue, that they're not trying hard enough. And that typically is the furthest thing from the truth. They're trying to exhaust everything, and we're missing that underlying dysregulation, and we're only thinking of the outside behaviors. And traditional approaches tend not to work in the same way.
Mm-hmm. We know how important it is to identify neurodivergent needs early, but that's especially tricky when a child's presentation doesn't match what we consider the typical diagnostic picture. Specifically when it comes to PDA, some people really consider this a profile of autism. I'm curious about what types of traits might we start to notice, recognizing that from the outside, those PDA behaviors can look a lot like defiance or oppositionality. And so you've talked a little bit about recognizing that it's about this nervous system response, but how do you help people understand that this is something that's different going on here? And what are some of the things that you begin to look for when you are working with a child?
Yeah, I mean, of course, I believe parents being able to do their own research and feeling validated by diving into this PDA world. And I would not let that stop families from pursuing a full comprehensive evaluation. Because the reality is, and there is some debate even within the PDA kind of world of, is it a profile of autism? We don't really have validity for that, but that's how we're often thinking of it. Some people think it can co-occur with ADHD, for example. But what I typically find in my practice is these kids that, quote unquote, feel PDA are actually really high masking autistic individuals, where we still can use traditional DSM-5 criteria. So that's how we diagnose. We can still use that criteria to say they meet for autism. And then so far, what we found in clinical practice is they also are meeting diagnostic criteria for anxiety at a minimum. So it usually, I like to think about it as these autistic traits as well as some anxiety. A lot of times ADHD is co-occurring with that as well because autism and ADHD co-occur at such a high rate. So that is the thing, is when we zoom out, autistic traits are still there. It's just really subtle. And a lot of these kids are missed of, oh, this kid isn't autistic. Maybe they get what's called an ADOS, the Autism Diagnostic Observation Schedule. They don't meet on it. And a provider is saying, nope, they're not autistic. And that leaves parents really confused. Sometimes we see these kids getting more of those ODD diagnoses as well. Mm-hmm. And so working with a provider who really understands high masking traits of autism and can parse everything apart, I think can be really helpful in all of this.
Yeah. I appreciate that you contextualize it that way. I feel like at our offices, when we do assessments, that is a similar way that we look at it. It's still going to meet those diagnostic criteria. But again, it kind of depends on how you are interpreting those results, how you understand what that presentation looks like. And a lot of the behaviors that we associate with PDA, like avoidance or meltdowns or shutdowns, also show up, like you're mentioning, like anxiety, or maybe they even look like OCD or even trauma responses. You mentioned that hypervigilance. Mm-hmm. I have to be honest, there are times I am concerned about that conflation between PDA and these other types of avoidant behavior. What do you see as the risks of misidentifying this, either in the clinical setting or by well-meaning adults who are supporting kids? And then how do you go about differentiating them during that assessment process?
I love that you asked this question because it's something that I am internally debating all the time. It's something like we have a team of psychologists in my practice that we constantly are talking about. And I think about it this way. If PDA, we're hearing from so many individuals how much they relate to this, but let's go to worst case. Let's say PDA isn't a real thing, right? What is the risk of that? And I think about it this way, is I would rather be wrong in an affirming way than be wrong in a non-affirming way. Because on a human-to-human relationship and connection, a lot of the PDA recommendations, while sometimes, and we can talk about this, I think low demand can go too far where it ends up burning out the entire family ecosystem. I think a lot of it is, how do we connect as humans? How can I believe what you say? How can I give you a sense of autonomy and equality where, is appropriate while still holding boundaries, with some key things, particularly safety. And so when I take a step back and say, okay, if we're wrong in this way, we're still validating this child as a human being. And that is what the autistic community is largely saying some of the problematic practices have been historically. Everything's been focused on their behavior, or they've been dismissed for the communication that they're having. Mm-hmm. And so that's the way that I err, but we are constantly reevaluating still, like our diagnostic reports. And when we're doing diagnostic evaluations, we're defaulting to the DSM and helping parents understand why this can explain PDA. We will include the PDA conceptualization in our write-up. And again, talking about how it can guide supportive approaches. So that's kind of our intersection between this neuro-affirming care and evidence-based practice.
Yeah, I feel very validated by this only because that is very aligned with what we're also doing in our practice and conceptualizing it, explaining it in the reports, even if we're not able to give a diagnosis of it, because we still want to be able to be within the framework of that DSM. Earlier, you mentioned ODD, or oppositional defiant disorder. And one of my theories is that there are a lot of kids out there who have an ODD diagnosis that probably are autistic and maybe fall within this PDA profile. I don't know. Agree, disagree? What are your thoughts about that?
Yeah, I mean, I completely agree. So before a little bit of context. Before I ever started learning about PDA, I mentioned I was in academia, I was doing research, and one of my areas of research was on emotion dysregulation in autism. And even back then, it was like, okay, when we think about autism, is it truly co-occurring ODD, or is it this underlying emotion dysregulation that, is really intense and, this kind of behavioral profile with rigidity as well? And I've always thought about it in that way. The research supports that. So layering on PDA, it kind of just continued that, and it gave more language, and obviously it's taken off. But I really do think sometimes I'm like, with ODD, the way the diagnostic criteria works is we're looking at a profile of behaviors. What is underlying that behavior? And whether it's autism, or the other thing I see a lot is that it's anxiety. The behaviors look manipulative. They look like very strong-willed and, defiant and all of that. But that's because we have a highly anxious child who is trying to avoid things or trying to control their situation for a sense of, control and autonomy over it. And again, then, is it also then co-occurring with autism? I think it happens more than maybe a lot of times we're hearing about. And real quick, this is a quick soapbox, but I think this is one of the harms within our mental health space of all providers not being trained on autism, right? There's so many that they learn the most basic understanding of autism. And I think this is where sometimes we get into a disservice, is we end up not even being able to officially rule it in or out. It's like, we'll hear from providers, well, I don't do that. And then parents get stuck with, okay, but this is what does fit. And it's like, maybe we need to be digging a little bit deeper, or, I have things I refer out for all the time that aren't within my purview, of being more mindful to refer out to people who really specialize in this space, like us, for example.
I think that's a really important point, because there are so many autistic people out there, a lot of them who are adults, who might be seeking mental health care, but because people aren't trained in it, they don't even necessarily know for themselves that that's what they might want to look for. And then if you don't have that as part of how you explore what's going on with a client, it's really possible that you're going to implement strategies that aren't really effective. And I do so much work with the schools, and I often talk about how neurodiversity affirming practices in schools are not just good for neurodivergent learners, they're good for all learners. But it's kind of the same with neurodiversity affirming therapy. It's like, if you know these things, if you consider the sensory aspects, if you consider the social communication pieces, it will help you tease out if autism is present and how that might help somebody with self-understanding. But also, there's no harm that's going to go into that for people who aren't.
Absolutely. I couldn't agree more on that. I would love to see more of this work filtrate in, regardless if you're working with, autistic clients or, ADHD clients, because the reality is, like, neurodivergence too is such a huge umbrella. We often associate it with autism and ADHD, but you can have anxiety, and some conceptualize anxiety, under that neurodivergence umbrella. So as mental health therapists, what we're getting referred is more likely than not a neurodivergent individual if we use this broad conceptualization.
Let's circle back and talk a little bit more about assessments. What are some of the considerations that you use when you are completing an assessment, trying to figure out if the PDA profile is what's going on is part of your diagnostic question? How does that shift how you administer or interpret some of the assessments?
I don't know if I can say for sure that we shift if PDA is part of it. And the reason that I say that is we are using a flexible approach no matter what in meeting the child where they're at. And so I think that's some of it, is really figuring out like how can we make them comfortable in, and we're doing fully a virtual evaluation. So how can we make them comfortable in this virtual interaction? You know, what can they bring in that's going to help them self-regulate? You know, we tell them from the outset, like, please allow your child to have fidgets. Please allow them to bring some of their favorite items. These are connection points for us. We don't require, a lot of times I think parents hear like a Zoom evaluation and they're like, my kid's not going to sit in front of the computer. It's like, I've done IQ tests where a kid answers a question, does a lap around the house and comes back for the next question and then does that again and again. And so it allows us to be really flexible. And so I think as a whole, that's the mindset we need to be using and realizing that this is an anxiety-provoking situation, regardless if their nervous system is overactive or not, and how can we meet them where they're at, help them feel most comfortable. But then we hear a lot from parents. We really value and center parent report as part of our evaluations as well. Because sometimes we don't get to see the PDA traits, right? It's only parents that are truly seeing those, but we're believing parents for what they're describing. But then after the evaluation or the assessment, the direct piece with the child, we're saying like, how did this compare? And a lot of families are reporting, wow, I'm surprised you ended up seeing more of what my child looks like on a day-to-day basis than I would have expected. And that's because of the accommodations we're able to provide.
You mentioned earlier that there might be assessments where somebody does the ADOS, which is a very common autism assessment piece. It sounded like you were alluding to the fact that it might under-identify some of these kids. And again, trying to figure out where that all stands as far as the research being emergent. But is that something that you see, that you experience with kids who are these high-masking kids?
Yeah, I'd actually say our number one referral in the practice are kids that have been previously evaluated for autism and parents were told that they weren't autistic. And then parents, go and try to integrate recommendations or something still, their gut is saying, I feel like I wasn't heard in this and they don't understand my child. So then they're coming for another evaluation. And a lot of times, it is that they're not meeting on the ADOS. But what is so enlightening is we read these reports because we will do record review as part of our evaluations. We literally can pull out the diagnostic criteria and be like, okay, like it's all here. You just didn't say it's autism. And I think sometimes I find as clinicians, and I found this even before I really got into focusing on neurodiversity affirming care and understanding the most like subtle presentations, is that sometimes the ADOS is misused in the sense that we rely too much on it to be the end all be all of, well, if they don't hit this cutoff score, they can't be autistic. And when we look at the research side of this, like the way sensitivity and specificity works, of course we're going to miss kids if we're using this hard and rigid piece. And Kathy Lord herself, who created the ADOS, says it's not meant to be used in that way. It's meant to be considered with other data and this comprehensive picture. And so I really believe that we need as a whole any measure. We should not rely on that as the end all be all. We get measures all the time, from schools in particular for these PDA kids where schools aren't reporting a lot. And so these kids are sometimes missed. And it's like, hold on, let's look at the pattern of behaviors and what we recognize and realize there's a lot of masking that's happening at school that is driving the teachers' low scores and not to report a lot of traits.
So once we recognize that PDA is part of the picture for some kids, our strategies have to shift. So what are some of the ways that traditional therapy or parenting strategies need to be adjusted when we are working with a child who has this PDA profile presentation?
Right off the bat, I think what parents think of when they hear PDA is this low demand parenting approach. And I think it's so important to recognize that, yes, lowering the demands can be helpful, but it doesn't mean no demands. Because if there are no demands whatsoever, that's where I find family systems get in burnout. So I have also a lot of kids who their parents have gone to low demand, but swung too far to the point, and understandable. Like, it's so hard to navigate, but they're swinging to this point of permissive parenting and then feeling like they're walking on eggshells all the time. And parents are in burnout, the kids in burnout. And we're actually working to add in and get more clarity on some of those boundaries. And so very briefly, I like to describe it. This is kind of a mix of using evidence-based practice, listening to the PDA field, trying to make it a little more tangible for families. I talk about the 3-bucket approach, where that first bucket are what are called the non-negotiables. The one thing that I always prescribe here is safety-related things. But then also what goes here is really key family values. This is so important to you as a family that you cannot drop this boundary. And so these are the boundaries we're holding, even if we know that the demand is potentially going to result in more activation and more dysregulation. But they're that essential. They are non-negotiable. On the other extreme, I have what I call the shoulds. These are a lot of things that are driven by neurotypical parenting standards or how you were raised as a child. And it's like, okay, well, no. If you find yourself saying, well, they should do that, actually asking yourself, why should they do that, right? And how much do you care about this in your family ecosystem? These are great examples of things that we can drop right away and go in terms of like that low demand approach for. Like, for example, like, why does your kid have to match if they really want to wear a certain outfit? Like, how important is that demand? And so it's being mindful of the number of demands that are accumulating for them. And then that third bucket is what I call either the ideal bucket or the yet bucket. The ideals of when your kid's in burnout, they're probably not going to be accessing these things. It could be something like sitting at a dinner table as a family. If your kid is having a really hard time, that demand probably doesn't feel accessible right now. Or it also can be things where there needs to be some skill building that has to happen before that demand can really, occur, or that boundary could occur. And so these might be the things that right now, especially if your kid is having a really hard time, is in potentially autistic burnout, we might be dropping these demands, but then we might think as the kid is gaining more skills coming out of burnout that we're slowly layering in. So that's like one example that I think is so important to think about. And I think it can be applied to therapy too. Where can we allow child-led approaches and allowing the child to lead come into play?
I want to make sure that we have a chance to touch on your whole family approach model, which I suspect maybe even aligns with what you were just sharing, which really emphasizes supporting caregivers, not just the child, which is something that I think gets overlooked in a lot of our intervention models. So when it comes to supporting a PDA kiddo, what does family-centered care actually look like in practice?
Yeah, I think it's thinking about the needs of the whole family system and the whole, I like to call it an ecosystem. And sometimes I'll hear parents say like, well, there's not space for my needs in this. But what we don't realize is then your nervous system is getting dysregulated. And I find for a lot of these like kiddos that fit this PDA profile in particular, they're hyper aware and hypersensitive to energy, right? They can feel when something is off. So taking care of your own nervous system in this becomes such an important part. So some examples of this, first and foremost, when you first get any diagnosis, taking some time to actually feel those emotions and process through that. And I do talk about with families, it can be a process of grief. You are not grieving your child, but you are grieving the shift in expectations. When they came into the world, you weren't thinking about the accommodations that, you would be making for them or what life would look like. Additionally, it's grief that they're operating in a very neurotypical world. And that means hardship sometimes because our world isn't always accommodating. And allowing yourself to process through those feelings. And a lot of parents, for example, just hop into action mode of like, what do I need to do for my child? And that's important. And it might not be, everything right now. Another great example, this also goes on the child side, but I'm a big proponent of quality over quantity of services and number of hours in therapy.
Mm-hmm.
A lot of times with an autism diagnosis, you get all this recommendation. But, maybe the one speech therapy slot per week is when your other child's soccer game is, and you're having to make a decision. And while I can't tell you what the right decision is, not defaulting automatically to like, no, we have to do this, right? It could be a big family value that you guys are going to soccer games. And maybe there's a little kid at the soccer game that your autistic kiddo connects with, right? That can be quote unquote therapy and learning and progress too. But we also can't always be thinking of just the autistic child's needs, because if we burn out the family system and burn out you as a parent in all of this, that's going to make it more likely that your autistic kid is also burnt out because they don't have that space and that person to be able to co-regulate with.
I love that so much. And in recognizing that, therapy can come in a lot of different forms, even if it's not just that one-on-one interaction with a therapist. So, well, Taylor, this has been such an interesting conversation. As we come to the end of our conversation, I have one last question for you. If you were talking directly to a parent who is struggling to find answers and figure out how to support their child who is exhibiting some of these traits, what would you tell them? What's the one thing you'd really want them to hear?
I think the most important thing is to follow their gut and intuition. The number of parents that I work with that knew instinctively what the next best step should be, and maybe someone discouraged them. I unfortunately see this a lot where pediatricians take a wait and see approach, or educators are like, no, we're not seeing anything here. But parents knowing that if you are struggling, that there is support out there and it doesn't have to be this hard, and understanding how your child's brain is wired and how to individually support them becomes so important. And yes, working with, providers and all of that are neurodiversity affirming, that believe you in this, but also remembering you are the expert of your child and no one will know your child to the same degree you will. And I always say yes, I know things about autism, but you know your child, and we need to partner together to figure out how best to support your child.
Yeah, I think that's a great place to leave it. Dr. Taylor Day, host of the podcast Evolve with Dr. Tay and founder of Tay Concierge Clinical Care. Thanks so much for talking to me today.
Thank you so much for having me.
Having a name for what you're seeing in your child isn't about putting them in a box. It's about making sense of their world. When we understand the PDA profile, we can start to see those confusing moments, not as defiance, but as something deeper. For families who've spent years feeling unseen by professionals or misunderstood by schools, that kind of clarity can be a turning point. It opens up new ways of connecting, new strategies that actually help, and most importantly, a renewed sense of hope that things can get better with the right lens and the right support. I'm Emily Kircher-Morris. I'll see you next time on the Neurodiversity Podcast.
Thanks again to Taylor Day. For links to her work, check the show notes. Also, thanks to all the mental health professionals who joined us last week in the Therapist Hub. We far exceeded our expectations. I'm looking forward to the great learning and conversations in the Hub ahead of us. You can put your name on the list for our next open window. There's a link in the show notes. Meanwhile, you can join our throng. Is that the word? Throng? Horde? Whatever, of social media followers and contributors. We're a growing and quite fashionable throng, even if I do say so myself. All of those links are in the show notes as well. Our host is Emily Kircher-Morris. Corey Orrick is our office manager and production assistant. I'm the executive producer, Dave Morris. For all of us, thank you for listening, and we'll see you next time. This is a service of the Neurodiversity Alliance,